Today we'll be talking about the pediatric major trauma. Although it is not as common as in adults, it is yet another emergency where the golden hour and platinum minutes play a very major role. In children, apart from polytrauma, we more often see something called traumatic brain injury, TBI as we call it. So in the next probably 1 hour or so, we will be discussing about pediatric major trauma as well as traumatic brain injury. So we'll just start off with a common scenario. A 2-year-old boy involved in a road traffic accident rushed to the emergency room after visiting a couple of other hospitals. He has a Glasgow coma scale of 13. Pupils are equal and reactive. He's tachypneic with subcostal retractions. Air entry is diminished on the right side. Saturation is 85% on room air. BP is 70/30 and heart rate is 140 per minute. His abdomen seems a bit distended and there is blood at the urinary meatus. There is swelling of the right leg with a cold right foot. Now this is pretty much all kind of systems involved if you look at head to toe. And trauma patient in the emergency room, be it adult or pediatrics, it means chaos. Chaos not only because the child is sick, chaos also because you will be involving multiple specialties. We'll be calling the neurosurgeon, the pediatric surgeon, the ortho people. So each one will be giving their inputs and will be calling out for certain labs. We'll be involving the radiology, ultrasound. So it's going to be utter chaos in the ER. So it is actually a good case not only to discuss about patient care, but also to discuss about team dynamics in the emergency room, to kind of role play, to kind of assign roles for each of the doctor and the nurse, and most importantly to identify who is going to be the team lead, who is going to be calling the shots. There's only going to be one leader, there's only going to be one captain of the ship whose orders have to be followed. So there is no better case than a polytrauma that can kind of take us through this. So mechanism of injury in children, commonest I would say is number 3, which is fall from height, followed by bicycle injuries, pedestrian struck by a motor vehicle, occupant in a motor vehicle collision, and non-accidental injuries like very rare these days, but what we talk about in the past called battered baby syndrome or shaken baby syndrome. Quite rare, but still cannot rule it out if you suspect foul play. So these are the common reasons how children may be involved in trauma. The goals of management are classified as primary survey, which goes hand in hand with resuscitation, identify and treat life-threatening injuries, determine extent of other injuries, which is called secondary survey, and last is prepare for definitive care. So we'll be talking about each of these in detail. Children are different. This is because the body size, especially the surface area, allows for a greater distribution of traumatic injuries. There is greater heat loss also because of the greater body surface area when compared to the body mass. The head to body ratio is much more in children, especially in small infants. So the incidence of serious head injuries is more common than in adults. Internal organs are less protected and hence more susceptible to injury. The skeleton, the bones are incompletely calcified and so they are more pliable. And so we may not see great amount of fractures in children, but green stick kind of fractures with minor falls are common. They are disproportionately irritable because of the factor of fear, separation from the parents, anxiety, all those put together with a child who presents with hypoxia or shock. So the irritability is way disproportionate when compared to the clinical condition. There is a greater capacity to maintain blood pressure despite acute blood loss, and that stress response, that catecholamine surge, is much more pronounced in children when compared to adults. So it just means to say that don't wait for the blood pressure to drop. If you do suspect that this child could be losing blood, then we need to arrange for blood as soon as possible from the ER. There is a persistent unopposed hypermetabolic state, which may result in hyperglycemia. And this also can contribute towards impaired healing and immunodeficiency. So there are multiple factors that come into play while determining the extent of injuries and determining the treatment in a child with polytrauma. There are multiple scores available for trauma. I am not sure if people will agree with this, or rather ER physicians will agree with this. We generally don't follow scores in our hospital. The reason being it's a tertiary care and everybody's trained to kind of pick out signs early. Scoring systems are usually meant for centers like, primary healthcare centers, or even a secondary center, level 2 center, where we have junior people manning the place. And so a scoring system will kind of generalize and tell that this particular score is bad and this particular score is okay. So there are several scores available for trauma. Many of them rely on the Glasgow-Coma scale, the respiratory rate and work of breathing, and the systolic blood pressure. So this is one such scale, but we do not as a routine follow it in our hospital.